Hello, everyone. It's Pauline from Chronically Spicy. Uh, Forgive the dishwasher in the background. We're basically chronically ill vampires because our internal clocks are completely messed up. So I am doing my usual trying to do a daily article read for mast cell activation syndrome, latex allergy, um, chronic illness in general, other conditions that I deal with, in order to help educate and spread awareness and advocate for awareness for ourselves and for the medical community. So, because there's a lot of misinformation when it comes to mast cell activation syndrome and a lot of misunderstanding, and doctors who truly just don't know. Not even kidding. I've been to two allergists in my area. I had to drive 40 minutes one way to see one of them, only to be told when I walked in that if he had looked at my chart before he made my appointment or agreed for me to come in for my appointment, he would have called me and canceled it because he doesn't accept Mcas patients. And I was like, uh, why? And he was like, and straight up 100%, the man said to my face, because not a lot is known about the condition, and it's hard to understand. It's really hard, to understand and treat the patients. And I was like, like not kidding. I flat out said, I was like, I know a lot about mast cell activation syndrome. I've been researching it for the last 17 years because it took me 15 years to get diagnosed, and I had to keep myself alive in the process. If you're ever interested in learning more about MCAS, I'm more than happy to sit down with you and any doctors you want to get together in the allergy field so that we can start creating awareness and you can start providing the services to MCAS patients in the area who are so desperately in need of medical care. It makes zero sense to me that allergists will not take MCAS patients in the area where I live. All right, so chronically spicy, Pauline, nice to see you. I'm sorry you're here because if you're here, that probably means that you're just, you're part. You got an invite to the party nobody wanted, and your bingo card sucks, just like mine. Okay, apologies for that because nobody wanted an invite to this party. All right, we are going to do a short-ish, maybe. We're going to do a read on an article from Mast Attack. I think it's mastattack.org. Give me 1 second for the screen share. There we go. 1 second. I want to screen share a different way so that you can see me in the corner. Here we go. There we go. All right. Now I'm in the bottom corner. Yay. All right. Okay. And if you happen to stop by, please do me a favor. Please like, please comment, please subscribe, share, engage, and let the algorithm know that you would like to see more of my content and support me as a content creator because that means that you're helping to spread awareness and advocacy for this condition as well. So I would very much appreciate that. Let's get to the article read, shall we? Where is it? It is right there. All right. Mast Attack is the article I'm reading from, mastattack.org. It's educating people about life with mast cell disorders, and it's written by a scientist living with mastocytosis. Mastocytosis is the most severe form of the mast cell activation disorders, and this is definitely something that I would love to share so that you can have an option for learning about different treatment options, some that are OTC, some that need to be prescribed. Always talk to your doctor. This isn't medical advice. I am simply sharing what I can for you to learn and help you maybe in the process figure out different ways you can search for the information that you need so that you can advocate for yourself when you go to your doctors. Okay? All right. Let's do the article read. Mcas treatment written by Lisa Klimas. It was written in October of 2014, but I will tell you, I have read it before, and this is all still completely relevant information. All right, article starts with this post discussion. This post discusses medications used to treat MCAS. Doses listed are taken directly from, quote, Presentation, Diagnosis, and Management of Mast Cell Activation Syndrome by Lawrence B. Afrin, who, side note, is a world-renowned mast cell activation expert. I believe his specialty is hematology. He's in private practice in the New York State area. Very expensive to see, but every bit of free content that this doctor provides in the form of podcast interviews and peer-reviewed journals in the medical journals, all of that worth its weight in gold. So if you're curious about MCAS, definitely look up Dr. Lawrence Afrin. And you can follow along if you're not watching on YouTube right now. You can follow along on YouTube because that's where you can see what I am reading from. All right, so these doses are general recommendations. Medication should always be taken under the direction of a provider who knows you and your case personally. Second sidebar, that means you need to be seen or should be seen or should be trying to find a doctor who is mast cell aware. Most doctors are going to flat out tell you if they are or they aren't. It's usually nicer when they tell you before you show up. But here you go. Next section of the article. MCAS is generally treated identically to ISM. I think that's indolent systemic mastocytosis, with the medications that block the actions of released mediators, that prevent the release of mediators, or that prevent the production of mediators. This is why you're going to find contradictions in lists of low histamine diet suggestions, because some foods are considered, this is a side note, some foods are considered, some foods naturally are high in histamine. Some foods become high histamine because of how they're treated or how they're cooked or prepared. And other foods are histamine liberators, meaning they aren't naturally high in histamine themselves, but they basically, kick off like a mast cell party in your bloodstream when they're ingested. So that's why there's so many contradictions. Back to the article. As a reminder, any medication that causes a reaction should be evaluated to see if it's truly caused by the medication or by a dye or inert ingredient, also known as excipients. Medications compounded without dyes or noxious fillers can truly be life-changing for mast cell patients. Generally, new medications can be trialed for 1 to 2 months to determine if they are effective. Antihistamines are first-line medications for both acute and chronic management of MCAS, but not for anaphylaxis. Epinephrine is the first-line medication for anaphylaxis always. Most currently available antihistamines either block H1 receptors or H2 receptors, histamine 1 and histamine 2, and are referred to by the receptors they block. It is generally recommended for MCAS patients to take medications to block H1 and H2 receptors daily as baseline medications. I'm currently searching for a safe H1 for me again because just found out the one I was taking I'm actually allergic to, and we're just about to talk about that one. Loratadine is a common H1 starting medication. It's a member of the piperazine family, and I have an allergy to an ingredient in all piperazines and a variety of, and too many medications to list right now. It has low anticholinergic activity and is not sedating. Dosing usually starts at 10 mg daily and may be increased by 10 mg 2 to 3 times daily. Fexofenadine starting dose in MCAS is usually 180 mg every 12 hours, cetirizine 10 milligrams every 12 hours, levocetirizine 5 milligrams every 12 hours, loratadine, which is loratadine, fexofenadine, and cetirizine are all available without prescriptions in the U.S., Of note, none of these medications are available for IV administration, so Benadryl should be used for emergency management of severe Mcas symptoms. I'm stuck in a situation right now where that's the only one that I have, because that's the only one I'm not allergic to. So I'm not really sure what to do right now. So I'm like trying to find, I might end up back at the Mayo in Minnesota. I'll be calling tomorrow. All right. Back to the article, there are several H2 blockers available in the US, most over the counter or OTC. Cimetidine and ranitidine have more drug interactions than famotidine and nizatidine. Famotidine peptide, which is also readily sourced for IV administration, is usually dosed at 20 to 40 mg every 12 hours. I'm prescribed 80 mg, so 40 mg twice a day. Though in severe cases, doses of 80 mg every 12 hours may be used. Okay, see, I always relearn something when I read these for you guys. Okay, this dosing is also seen in Zollinger-Ellison syndrome patients. I need to look. I don't know what that condition is, but we need to look it up later. Ranitidine starts at 75 mg every 12 hours, increasing to 300 mg every 12 hours. Nizatidine Acid is dosed at 150 to 300 mg every 12 hours, and cimetidine at 400 mg every 12 hours. Side note, I know that a lot of Mcas patients actually have to be like titrated up to the starting dose. So like when I get put back on hormone sodium and low dose naltrexone LDN, which is a mast cell stabilizer, it's going to probably take me 6 weeks just to titrate up to the starting dose. So it will take even longer to get to the full recommended dose that my doctor wants to put me on. Back to the article. There are several other medications with H1 antihistamine effect: tricyclic antidepressants, phenothiazine, antiemetics like promethazine, and quetiapine, an antipsychotic, both of which I'm allergic to because of ethylene hydrochloride allergy. They are all H1 blockers. Addition of these medications often helps even when another H1 blocker is being taken by the patient. In particular, use of doxepin has been well described. It is usually started at 10 mg twice daily and can be increased by 10 mg twice daily to two doses of 40 to 50 mg twice daily. Beyond this, exhaustion and grogginess are often intolerable. That's just a side note. That may also depend on whether or not you have ADHD and how severe it is. Because and I'm not giving medical advice. I'm just sharing personal experience. But my daughter takes hydroxyzine, and she's taken it since she was 2. And we were told that if that not to give it to her before school, just before bed. It does nothing for her. I don't get tired from diphenhydramine or any medication that I can take because my brain is just wired backwards. So anyway, ketotifen is a medication with both antihistamine and mast cell stabilizing properties, meaning it interferes with the release of mediators, and that's what we want. We want to stop the release of mediators. The oral use of this medication for mast cell disease management is not well described, in part due to the oral formulation not being available in the US. Dosing is usually started at 1 mg twice daily and increased in increments of 1 mg twice daily until desired effects are noted and balanced with an acceptable side effect profile, as described by Dr. Afrin. Single dosing is usually 6 mg or less and can be taken up to 4 times a day. She doesn't explain in here. She does say that the oral medication is not available in the U.S. The kind that is available in the U.S. is eye drops. I need to look that up and see if I can take that, because my ethylene chloride allergy has eye drops listed as one of my hundreds of, yeah, you can't touch this. So I need to see if that one's safe or not. All right, I have to be careful on how to phrase this one. So if you want to, please check out my YouTube channel if you're not watching on YouTube, because then you can read, and the live will stay up in my mast cell activation syndrome playlist as a video after the live has ended, because there are certain words that the other apps don't like. So we're going to call these the Mercedes-Benz class of medication. I'm going to, these are medications that are commonly used to treat anxiety, panic attacks, and agoraphobia. And they are controlled medications. So that's as much as I can say. So I'm going to say here, the Mercedes-Benz class are often helpful in Mcas due to both its actions on mast cells and also directly on organs, particularly GI organs. There's another one because the entire class of the Mercedes-Benz class of medications uh, have mast cell stabilizing properties. The one that starts with L and ends in PAM. There's one that starts with clone and ends in PAM. And then there's the generic form of the one that starts with the letter X and ends with the letter X, but the generic starts with L and ends in PAM. Are preferred due to their shorter window of action, meaning, and I'm explaining in the sidebar here, these medications usually take 15 to 30 minutes to take effect. So if you're having an Mcas histamine mediated release, and you're having multiple, you're just not having a good time, these can take effect, and actually, I've personal experience within 15 minutes usually. I'm usually stable again. Other medications in the same class could have a 30 to 60-minute window. So it could depend which one your doctor prescribes for you, depending on what your pattern is. Like, doctors know that I usually react within 2 bites for 5 minutes of eating the food that is going to trigger me. So that's why I'm on the one that I'm on. Also because I react to the rest of them. So there we go. All of these, back to the article, all of these Mercedes-Benz class of medication dosed beginning at 0.25 mg every 12 hours, increased by 0.25 mg twice daily every week. She does not state in the article what the max dose is recommended by Dr. Afrin, but I can look that up for a future video if anybody wants me to look that up. Let's see, flunitraz enzympium has been described in treatment of mast cell disease. This medication has a longer half-life, which generally means it takes longer to take effect, but it stays in your system longer, so you stay stable longer as it builds up. Is generally dosed at 0.5 to 2 mg once a day. Imatozapyridine medications like zolpidem, Ambien, also act on the Mercedes-Benz receptors of the body. Though usually taken for insomnia, some Mcas patients report relief of other symptoms. Whether or not these medications work in a patient seems independent of whether the Mercedes-Benz class of medications are currently being taken by the patient or have worked or failed in the past. So that's something to keep in mind. Non-steroidal anti-inflammatory drugs, NSAIDs, can be helpful in Mcas patients who can tolerate them, because we all have, as Dr. Afrin has stated in other articles that I've seen from him and podcasts in which I've seen him, we don't all have the same perfect cocktail of medication, and it can take years to find like the right combination to actually reach like good quality of life. Right now, I'm literally just surviving. All right, so in particular, use of aspirin to bind prostaglandins has been very well described. A common starting dose is 325 mg twice daily, with dosing up to 650 to 1300 milligrams twice daily seen. Some patients take as much as 1300 milligrams 4 times a day, but doses higher than 2600 mg a day are unhelpful in most patients. Again, everything that is being stated here is information that is coming directly from Dr. Lawrence Afrin himself, a noted, world-renowned, peer-reviewed medical journal published Mcas expert. So all of this is coming from that, and I do have the article link. The source article is linked in the description box on my YouTube channel, and this will go into the Mcas playlist. Non-enteric coated aspirin seems to be better tolerated and more effective at relieving symptoms in MCAS than the enteric coated. In MCAS, patients for whom aspirin is inappropriate, such as those with low platelets or decreased kidney function, COX2 inhibitors like Celebrex are sometimes used. Celebrex dosing in these patients usually begins at 100 mg twice daily and increases up to 400 mg twice daily. Leukotriene inhibitors are frequently used in MCAS. Interesting point. That's how my MCAS was confirmed by the Mayo Clinic. I have sky-high leukotrienes. Leukotrienes that are elevated contribute to chronic inflammation. Montelukast is the most common, being dosed at 10 mg once to twice daily. Zafirlukast, Zafirlukast, is dosed 20 mg twice daily. Doses should be decreased appropriately if liver dysfunction is also present. Cromolyn is the most well-known of mast cell stabilizers, despite the fact that the mechanism by which it acts is still unclear. More recently, it has been noted to block mast cell receptor 35, which is increased when IgE is present. Note, we only have treatments for known treatments for H1s and H2s, right? And this one's for histamine blocker 35. There's a doctor that I follow on YouTube. I'll be doing a reaction to a few of his videos because he noted that we literally have, we only know four of the, I think we only know 4 specifically of the histamine mediators that are released and how to treat them, and we're still learning, and there are hundreds more. And we don't even know what they all do. So anyway, cromolyn is noted to block mast cell receptor 35. Cromolyn is extremely poor absorption, with 98% of oral doses being excreted unchanged. Let me read that again. If you're taking or prescribed, or your doctor's thinking of prescribing the liquid vial oral cromolyn sodium that you're supposed to squeeze into your water and drink up to 4 times a day, 98% of that is going to be quite literally urinated out of your system. It's going to pass right through. When inhaled, there is in a nebulized form of cromolyn sodium. And there is also do I have it over here? Probably not. No. There also is a nasal crom nasal spray that's available on Amazon. I'm not telling you to buy it. I'm not recommending it. I'm just telling you that it exists. It's without a prescription, and it is straight up exactly the same as the cromolyn. So any other kind of cromolyn, so it's cromolyn, sodium, and sterilized water. And one of my doctors was like, "That's just buy that." Inhaled cromolyn sodium increases the effective amount to about 5%. So instead of 2% being retained in the body, if you're doing or taking the oral doses of cromolyn sodium, the inhaled or nebulized versions of cromolyn sodium are going to increase the effective medication that stays in your system and works to about 5%. Oral dosing is from 100 to 200 milligrams 2 to 4 times daily. When nebulized, wait a minute. When nebulized, dosing is usually 20 milligrams 2 to 4 times daily. Of note, patients usually experience a resurgence of symptoms when first starting the medication that may last 3 to 4 days. In my experience, the symptom increase is sometimes observed when increasing the dose. It can take several weeks to determine if cromolyn is truly effective in patients, with some people only seeing serious gains after 4 months. And this is why many doctors, like my nurse practitioner who diagnosed my Mcas initially, she refuses, well, this is her policy, and I completely go with what she says, is to basically start me at the baby dose and tippy toe my way up to the full dose. So like it's going to take me 6 weeks from starting point to getting to the the starting dose. And then from there, every other week or so, we're going to go up like another tiny bit. And if I have any symptoms, we go back down for a week and then we try again. So keep all of that in mind when talking to your doctor about medications that are options for you. Feel free to take this link in the description box, print it out, take screenshots, whatever you need to do, and show your doctor, because this is information that comes, again, from Dr. Lawrence Afrin. If your doctor doesn't know who he is, world-renowned Mcas specialist that many doctors go to to consult when they have patients that they don't know what to do with. Let's see. Okay, next paragraph. Pentosan, Pentosan, is the less well-known mast cell stabilizer whose mechanism is likewise unknown. The medicine is commonly used in interstitial cystitis, a mast cell disorder that affects the genitourinary tract. I apologize if I butchered that word. Though Pentosan seems to be the most effective in the GU tract, some patients report decrease in other symptoms while on this medication. It is usually dosed at 100 milligrams every 8 to 12 hours. Quercetin is commonly mentioned as a natural homeopathic mast cell stabilizer. After much research on the topic by the author, who is a scientist living with mastocytosis, she says, I have to say that I agree. It has been found to inhibit lipoxygenase and cycloxygenase, CYCLOOXYGENASE, which in turn decreases production of leukotrienes and histamines. Okay. Might be worth revisiting quercetin, because that's where my problem lies. My quercetin levels are through the roof. It is usually dosed starting at 500 to 2,000 milligrams per day, divided in 2 to 4 doses. For example, a daily dose of 500 mg may be taken as 125 milligrams 4 times a day. A newer form quercetin chalcone, CHLCONE, is usually taken at 250 mg 3 times a day. I will have to look that one up because I've never heard of that one, and I need to see what is in that one. Pancreatic enzymes like creon, CREON, are sometimes helpful in Mcas patients who have pancreatitis symptoms. Even if they are not having pancreatic type pain, it sometimes helps with the chronic stomach upset, weight loss, and malabsorption. Corticosteroids. I'm allergic to the entire class, and there are 3 that can safely be compounded for me. So I'm just waiting for my prescription, hopefully soon, because I have not because of the mast cell, just mast cell, but because of a condition I have called Behçet's disease, and that's how it's treated with corticosteroids. They're sometimes used to manage mast cell symptoms as well. These medications can prevent Mcas from producing mediators, and as such can be very effective. However, long-term use can have severe side effects and is discouraged. So I believe it depends on the doctor and the severity of your condition, but some doctors are going to say, yeah, you need to take it for just flares. Some doctors are going to say you need to take it all the time. I know patients with systemic lupus, have to take it like daily for like the rest of their lives, and it can really mess with a lot of things. So that's why it's usually prescribed in for shorter windows when things get bad to help stabilize. Omulinizab Xolair is an anti-IgE antibody. It is not clear exactly how this stabilizes mast cells reacting by a non-IgE mechanism. Xolair is injected subcutaneously at doses of 150 to 300 mg every 2 to 4 weeks. It should be treated or trialed for at least 3 to 4 months before determining if it is effective. Interestingly, whether or not a patient responds and how well seems to be independent of the pretreatment IgE level. Also extremely important to note, and I'm going to note this because I have both of these allergies, and so you're aware. Xolair comes in 2 forms. One is a prefilled syringe. The prefilled syringe contains latex. That's stated you can find it online. That is stated in the Xolair information info sheet that you can find online if you just Google for it. And Xolair patients are also told to carry epi because you can have an anaphylactic reaction at any time from taking Xolair. Keep in mind, latex allergy is progressive and has no cure, and it's repeat exposure to latex that can actually trigger or increase the severity of the allergy. I'm not saying don't take this. I know it's been extremely life-changing and has incredible effects for many people, but I think it's important for people to be aware. The second form of Xolair is the kind that needs to be administered in the doctor's office. It does not come in a syringe, a prefilled syringe. However, both the latex-free version of Xolair and the latex-containing prefilled syringes both contain a polysorbate, which is a coconut derivative, and a latex allergy cross because of shared cross-reactive proteins. So for that reason, as much as I would love to try and see if it would be as amazingly life-changing for me as it has been for other people I know, it's completely off the table. The successful treatment or use of the successful use of chemo medications for severe Mcas cases has been described in literature. In particular, hydroxyurea can be effective, though rapid onset and severe low blood cell count are a real risk. It is usually started at 500 mg daily and increased up to 2,000 mg daily. as needed. Blood count should be monitored weekly for 4 weeks at the onset of treatment and after any dosage increase. Tyrosine kinase inhibitors like imatinib and dasatinib, DASHEINIB, have also been used as last resorts in Mcas patients. That's a depressing sentence. 1 second. Okay. Imatinib is usually dosed at 100 to 200 mg daily, and clasatinib at 20 to 50 mg daily. Patients on these medications require careful monitoring for pulmonary and renal issues. All chemo patients are at an increased risk of infection. And last paragraph in this blog post on mastattack.org, which again, the source link is in the description box on the live, which will end up living in my mast cell playlist after I have updated that. IV hydration is being used more frequently to manage baseline symptoms for MCAS patients. TNF alpha inhibitors have been suggested. Pardon, I get bubbly with my mast cell and allergy flares. And right now, flaring like it's my job. TNF alpha inhibitors have been suggested to help mast cell symptoms, but there have been no symptoms. What? TNF alpha inhibitors have been suggested to help mast cell symptoms, but there have been no symptoms. I take a TNF alpha inhibitor for autoimmune issues and do find it helps to relieve some of my mast cell symptoms. I'm wondering if she missed a word there, but anyway, that's an option you can talk to your doctor about. Other possible avenues include IL-1 and IL-1B inhibitors and kinin, KININ-B2 receptor blockers. Tryptase inhibitors continue to be in development. Note, and this is the sidebar I am adding, only about last time I researched, only about 30% of patients with MCAS actually show elevated tryptase levels during flares. And I've had multiple people with mastocytosis in my comment section tell me that about 18% of people with mastocytosis do not show elevated levels of tryptase even during a flare. So this is 100% super important for people to be aware of, because the gold standard testing that a lot of doctors will immediately kick MCAS off the table as a potential diagnosis to consider and treat is based on only 30% of the population that's affected. So keep that in mind. You can also ask for a leukotriene testing if you're looking, if the doctor is like, we need to have something that is, showing this. You can also research MCAS Consensus 1 and MCAS Consensus 2. Dr. Afrin helped develop MCAS Consensus 2. The reference is from Afrin Lawrence B. Presentation, Diagnosis, and Management of Mast Cell Activation Syndrome, 2013, Mast Cells. There we go. All right. So 1 second here. Stop sharing. And we are back over here. Hello. All right. So, I do pay attention. I read a lot of peer-reviewed medical journals. I read a lot of scientific journals. I read a lot of medical publications that are meant for doctors treating mast cell activation syndrome, because I have to, because of the severity and the insanity that comes with all the allergies I have that kind of make, hey, well, you should be on this and this and this. And I'm like, yeah, well, It can't be because I'm allergic to too many things. So I'm like a unique case in that aspect. My daughter has mast cell activation too, and and she can take plenty of these medications if they're prescribed. So just it's good to be aware of where you are. If you're, keep track of your own triggers, keep track of your patterns. Open up your notes app on your smartphone and just like ate this at like what time, right, what time you ate, then like what your symptoms are when and if you start to react. And I always keep a video diary or a phone diary. I have a photo album in my iPhone called "It's All in Your Head," in honor of every doctor that's ever medically gaslit me. And that one dates back 15 years. So yeah. I hope this article was a helpful bit of information for you and perhaps a good starting point for you to be able to take this information to your physician or to a mast cell activation specialist, rheumatologist, whoever it is that is treating your Mcas, or if you're looking to get diagnosed, or to find out if you have Mcas and be evaluated. So this is hopefully a good way to get the conversation started. I would appreciate if you would please hit the like button, please subscribe, please leave a comment, please share, and I will see you in the next video. And again, if you have any specific questions or topics you'd like me to cover, take a look at my playlists, see if I've already covered the topic. And if it's something that's not there, let me know in the comments section. And I will be more than happy to take a look and see what I can do for you. Have a lovely evening. Have a good day tomorrow, as good as you possibly can. And I am wishing for you that you have a low pain, boring day with zero reactions, because I miss being boring and I'm sure you do too. All right. Have a good one. I'll see you in the next video.